All of you that haven't found your way to your table, would you please do it quietly so that we continue with the rest of our program. We have a tremendous amount of great information for you this afternoon. We want to make sure that everyone has an opportunity to hear it and to hear it clearly. So if we can end our socializing piece and focus back to our informational session. I want to apologize. One of our sponsors, Indiva, I failed to mention earlier, and I want to make sure that I made that clear because we do appreciate you, and we welcome all the participation that you have given us and the support that you have given us. We've been given many facts and figures this morning already. We've learned about addiction and how medicines are helping. But why does all this matter? Because treatment, help, and understandings are not reaching everyone who needs them.
Can you also make an announcement if there are any empty seats next to you that somebody can raise their hand?
Okay. These are the gaps in care and access to care, which Dr. Corey Waller will address. Now, before I go on with Dr. Corey Waller, are there any, we're at capacity now, and are there any seats that are next to you that that are not occupied? Would you please raise your hand? Okay, staff? Raise your hand again. Okay, are we good? Dr. Waller is an addiction, pain, and emergency medicine specialist with the Spectrum Health System in Grand Rapids. He is the medical director of Spectrum Health Medical Group Center for Integrative Medicine and medical chief of staff for the medical staff chief of pain medicine to the Spectrum Health Hospital System and president of the Michigan Society of Addiction Medicine. He is also a member of the state of Michigan's Prescription Drug Task Force. Dr. Waller.
Thanks. Thank you for having me this morning. And I didn't get a chance. I got stuck in Novi because 2 inches of snow on the highway, in this state shouldn't be a problem. But I got a lot of time to look at the side of the road around there and look at the exit I couldn't quite get to. But we made it on time. So the people that you heard from before, I've worked with pretty closely over the last couple of years. And so I'm not going to go back over the things that they talked about because we understand that opioid use disorder, alcohol use disorder, gambling, and many other things fundamentally have to be readdressed as a chronic neurobiological disorder and not a problem with decision making. So we're going to assume, as I start to talk about the gaps in care and how we fill those gaps, that is just understood. I'm not going to try to sell it because I have a mountain of data this tall that says that it's true. I'm a neuroscientist, and I've seen the neuromolecular biology that backs up the changes in the brain that tell us that this can be both a permanent issue as well as something that, we can improve, stabilize, and in many cases, get them right back to where they wanted to be before they went down this pathway. But without access to the appropriate types of care and the appropriate wraparound services and the chronic disease model of approach, we're really not going to be able to take the vast majority of these patients much past detox. And it's important for us to understand what those pieces of the puzzle are. So today I'm going to talk about what we need to do from a prevention standpoint, what we need to do from an identification of all the services that should be available to patients in every region, and then how we start to build payment models and the approaches around that so that those of us who treat this disease have access to the things we know are helpful for our patients. And for those of you who have family members with this disease, or you yourself with this disease, will have access to the appropriate treatments. Because right now, we have created a system that focuses on very few things that have rock-solid data by themselves. when we start to add all of these things together, that's where the data, science, and math coalesce into positive long-term outcomes for patients. And so how do you define, or how do I define positive long-term outcomes? The disease of addiction is diagnosed based on behavior. The DSM-5 diagnoses it with 11 criteria. 9 of those are behavior-driven, and it's the behaviors associated with obtaining or using the drug and how that impacts your interpersonal relationships, your social capacity, and your work and your health. It's not necessarily just being on a drug. If that's the case, then if it was just being on the drug and a positive urine drug screen, that would sure be easy. If we had a blood test for addiction, if we had a urine test for addiction, or an oral fluid test for an addiction, that'd be great. We don't. This means we have to talk to people. We actually have to interact with them. And a screening is not a urine drug screen. A screening is a sit-down conversation face-to-face with that patient and their family if they have it, and the people around them if they're available. Because we need to understand how all of those aspects are impacted either positively or negatively by this person. Because without that, we're not able to make a decision about the next step in treatment. So how many people here know that we have a criteria that allows us to know exactly where to put a patient based on a set of questions and the severity of their illness of addiction? Right. Now we actually, so small number of hands, right? This is the ASAM criteria. It's accepted nationally. This is a criteria, unlike many other diseases, that allows us to determine severity, and not only severity, but where they go for treatment. I mean, we have this. It's validated and known. We've had it since 1991. And it's been updated and continually made better over time. So it's not like we have to do what I say or how I say it. We have a tool that's been decided on for severity of the illness. How many people in here know that we have medication that, well, I guess you do now, but before you showed up this morning, how many people showed up and knew that we had 3 medications that have large amount of data behind it that shows that we can decrease relapse and decrease their total diagnosis based on the DSM-5 of addiction by up to 70%. I mean, a lot of people, when I go and talk, people just generally don't know that we can treat this disease with up to 70-75% effective rates without magic, without unicorns and rainbows. We can actually treat it based on evidence, data, and the science behind it. And when we do that, we don't have to have big, shiny new brick buildings. We don't have to create entirely new systems. We just have to coordinate the ones that exist and expand the areas that are contracted. What about prevention? We talked about, and I don't know if the Lieutenant Governor brought this up or not, but one of the statistics that always hits me is the fact that 72 to 75% of people on heroin started on prescription opioids. That makes us a cause from the medical field. This is, in my estimation, the largest iatrogenically caused, conundrum in the history of the United States. And iatrogenically means I caused it. Right? And I have to roll myself into that because for the first 5 years of my career, I worked in an emergency department with the same level of training as everybody else, which was basically none. I always laugh a little bit. They go, how much training did you get? And I said, well, I got, talked to by an anesthesiologist who had gotten busted using fentanyl, and that was my addiction talk. That was my whole life lesson in addiction in, between medical school and residency, and it was more about how not to get caught than it was about addiction. And then my pain talk was about how much Dilaudid I can give somebody before they stop breathing. That was basically it. And they said, well, you just kind of give it till they get really tired. Well, thank you for that rock-solid science base of evidence. But then all of a sudden, we were mandated to treat pain, right, as the 5th vital sign. Interestingly enough, it's a vital sign that you can't measure, that you got to guess at. There's no blood test. There's no cuff, no little thing that goes on your finger. No EKG. It's not. You just say, do you feel pain? If somebody's life is pretty bad and they don't have good housing, their family's really tough to deal with, they have a lot of early life trauma, even if they're not injured, they have pain. And we call that suffering. And how have we treated that suffering? Pills. Here's the magic pill. Here's some Oxy. Good luck. Here's some Xanax. You'll feel totally better after this. But then I forget to tell you that this is only meant for you to be on for about 20 days, and then we should wean it off. Because if you're on it for greater than 6 months, it causes structural changes in the brain that don't allow you to get a hold on your anxiety. We forget that little part. Or when we write an opioid, we say that all of the data shows that even after a surgery, 3 to 5 days is all you need for opioids. 3 to 5 days. I had neck surgery 2.5 years ago out of state. Well, it's out of the state, so I can throw them a little bit of a verbal beating, right? So it was Northwestern. I went there because a friend of mine is a minimally invasive spine surgeon in Atlanta, and I asked him, where should I go? Because I had a disc pushing on my nerve, and I couldn't work. You know, I was like trying to type like this, and he gave me this guy's name in Northwestern. So I went there, and they went in and scraped off the disc and a bone spur and all of that. Surgery on a Wednesday morning. I had pain meds. So here's the funniest part of this story. I had not had any opioids for pain up to the time of after post-op, and then I refused a little bit in the post-anesthesia care unit, so right where you go after the operation. He's going to give me like a big dose of Dilaudid, and I'm like, no. I'm sure I said something, but it probably was unintelligible. In my mind, it made sense, but who knows what it actually was. And then so he didn't give me much there, but then when I went to the floor and I said, can you just give me my meds every 4 hours the way they're written without, asking me in a sense, because I know that's how it's ordered. I'm a pain doctor. I didn't tell them that. I never tell them I'm a doctor because then they get out of their comfort zone and they start doing weird stuff that makes you get infections and stuff. They're like, we're gonna check it a few extra times, like stop touching me. But then I heard it sign out after I asked the nurse this. She's at the door with it open, talking to another nurse, signing out, and she goes, he asked for these medicines by name and by time, so I think he's probably a drug seeker. So I kind of internally laughed a little bit. And the scary part, that's the funny part. The scary part is I was up and showered and dressed the next morning to leave before they even had rounds and was ready to go. They walk in the room, and they're a little taken aback about the drug seeker. And then when they look at me, they say, well, here's your pain prescription. So they had information that I was possibly a drug seeker, however ridiculous that was at that point. And yet they walked in with the prescription in hand for 90 instant release 10 milligram oxycodone. Wow, neat. And here's the other part that was really scary is I said, no, thank you. I'm okay if you could just write me for some prescription strength Motrin. And if I need some extra pain meds, I'll talk to my primary doc when I get back to Grand Rapids. They freaked out. They're like, no, you can't not leave without this. You can't, you have to take this. And because it's like a box you got to check, right? We address the patient's pain. They could have addressed the pain by saying, how is your pain? And I would have said, it's really not that bad. You guys did a good job. But that's not what happened. They were like shoving an oxycodone prescription down my throat, and I'm just laughing at the same time. And so I finally said, you guys know, I'm an addiction doctor and a pain doctor. And so I think your intern who wrote the prescription and who checked the box probably knows a little less, maybe a touch, than I do about maybe utilizing some of these medications. And still, the chief resident of minimally invasive neurosurgery, the fellow said, sir, I'm sorry, you just have to leave with it. So I left with it, walked down to Starbucks with my dad, tore it up, threw it in the trash. And so, but that's really weird, right? That's just odd. So prevention starts actually with education of the prescribers about what the data says, because we don't have data that says that long-term utilization of opioids is helpful. We actually only show harm. So there's a little bit of a fight going on right now because the CDC guidelines really walk back, the draft of the CDC guidelines walk back the utilization of opioids, and they walk it very far back. And so at first, everybody was in agreement. Now there's a minority of people within the pain treatment community that are screaming about this, and they're screaming, well, we can't abandon this. Just because, and this is actually stated in the New England Journal of Medicine as one of their arguments, just because we don't have data that shows that it works doesn't mean we should abandon the treatment. What? 9,000 people? We have 19,000 people a year that die of overdose from opioids, prescription opioids. And then Vioxx, which was a great pain medication, by the way, possibly had 2 people die prematurely of cardiogenic disease, accelerated heart disease. 2 people pulled that thing right off the market. This is the reason that they're freaked out, because I've talked to a few of them, and they're worried about this. Because you know what? The things that actually show good data, science, and math for the treatment of chronic pain, we don't pay for and don't exist in any capacity. So if we stop and we turn off the access to opioids, what we're going to do is immediately turn on an even higher and more accelerated utilization of things like heroin. Because when you have significant poorly treated pain and a genetic predisposition for addiction, logic and risk assessment goes out the window when you're in pain and you are suffering because of your sadness as well as your pain. And then when somebody says, you know what, a family member or a friend gives you some of their pain meds, or hands that off, and then somebody says, but that's $100 to buy from a friend to get some oxycodone. All of a sudden, $10 bags of heroin seem okay when you're suffering like that and you have this genetic predisposition. So turning off that one piece without turning on the expansion of the treatment capability within the opioid use disorder world is basically system malpractice. Because we know this. We've already seen this happen when we made oxycodone abuse deterrent. So we know that it works, because I get asked this question a lot. How do we know that these abuse deterrent formulations work? And I laugh because when, if you just look at the basic data of utilization of oxy being found on the street goes like this, at the same time heroin goes up like this. I mean, it's a match. And so that tells me that it is abuse deterrent, and then it's not available on the street. And what we're going to see, despite all of this outpouring of worry about, appropriately so, of the epidemic of opioid overdose that we have in this state and across the country, is actually not necessarily all of the action required to help those people that we're going to turn off when we start to turn off the opioids available, because that's already happening. A lot of primary care docs are just saying, oh, well, I've been told I can't write this anymore, and so I can't write it anymore. And then we have a bunch of people in withdrawal. And we have people getting fired from primary care offices. We have people that have been orphaned from the healthcare system because they have either addiction or chronic pain or both, and neither are being addressed appropriately. On the prevention side, we have to decrease the amount of meds that we write, but we have to do it in a humane way, which means a weaning, education for for the people writing the prescriptions, decrease the short-acting meds on the street. These are things that we know. We put all of that into the task force document. But how do you even know if your patient is getting medications from another place? The Michigan Automated Prescription Service was actually one of the first out of the gate. It was one of the first ones in the nation to actually be working and help us to track these medications. But right now, it is a dinosaur. And on every Monday, when I worked in the emergency department, when we tried to use it, it would go down. Because Monday is the busiest day in the emergency department and most offices. So if you mandated every person to check it before they prescribe something right now, it cannot actually make that happen. So everybody would check it. It would be down every single day. It would just be out of business. We know this. Laura knows this. Mike Zimmer, the head of the director of Licensing and Regulatory Authority, who this sits under, fully understands this. And so we have to push as a community to make sure that in the budget coming up, that there is an allocation of funds and in a direct appropriation for the building of this website. Because it has to be available to us, and if you want us to know, it has to. And what's funny is that the places that have mandated this, I'll tell the story of an insurance company in Northern California who saw that this was an issue. They ran their own data internally and said, these are all the patients on very high doses of opioids, so what we're going to do is we're going to go ahead and run, and in California it's a cures report rather than a MAPS report, so they would run that report for the office and give it to the office. That saved them almost $7 million in pharmacy costs while providing a service to them, because the number of opioids and benzodiazepines and stimulants written decreased by about 50%. So just having the data helps us to make better decisions. But then we also saw right after that, and they tracked this, a higher mortality rate for their younger groups, because what they would do is go to get something that they could to help it. So without the backup and where to go and the system around that to be built, then what we did is we basically said a subset of people are going to have a higher mortality rate based on a system change. So if I increase the mortality rate of my patients, I get in trouble for that, as I should. But what happens when a system increases the mortality rate? What happens when a a payer or a PIHP region or a state government or the federal government increases mortality knowing there's a better way. Isn't that malpractice? I mean, to me, this is something that we don't have enough conversation about, because the more I look at it, if somebody comes into the emergency department and they're having a heart attack, and not even a bad one, just what we would call a non-ST elevation MI, all right? So this is a heart attack that we can see on a lab, but not on an EKG. They have a 30-day mortality rate that is less than someone who shows up in that ER that overdosed. So that means that a heart attack has a lower death rate in the next 30 days than the person who shows up status post an overdose in that same emergency department. What do we do with that person having that heart attack? Boy, they get admitted, echocardiogram, stress test, heart cath, massage, nutrition, whatever, I mean, rehabilitation, all of these, I mean, this is just the normal path. And if you don't do it, then the health system is punished. If you miss giving that person an aspirin, I will tell you, I have an email in my inbox the next day. Do you realize that you did not give that person the 324 milligrams? Because it's not 325, it's all these little baby aspirin because they can chew it. I mean, there's like very specific set of stuff that does not, the number needed to treat by giving aspirin, meaning the number of people that I have to give aspirin to in a heart attack to make better, is about 1 in 20. So 1 out of every 20 people I give aspirin to, I can improve their outcome. And if I don't do it, it's malpractice. For buprenorphine, methadone, or naltrexone, what is the number needed to treat for that? 1 in 1.7. So for less than every 2 people that we use medication-assisted treatment with appropriate wraparound services, we do positive good. What about the number needed to harm? So let's look at like a cholesterol medication, statin. This is commonly given to a lot of people with high cholesterol. I know my dad was like, can I just take this med so that I can keep eating Bluebell ice cream? And I was like, don't you know that guy just got shut down for listeria? And he's like, whatever, I like it. I'm from Texas, so he eats it. But this medication is prescribed to millions of people, and the number needed to treat, meaning the number of people who need this medication to decrease a hospitalization, is 1 in 60. So there's 59 people who take this medication who don't get any benefit from it. How many people does it take to actually cause harm? 1 in 20. So 1 out of every 20 people will require a hospitalization for medication side effect or problem. So really it's a 3-to-1 ratio of harm to good, but we just put that in the water, right? It's like everybody, it's just a part of what you get. The number needed to do harm with the medication that everybody's freaking out about with like buprenorphine and methadone and Vivitrol is about 1 in 65. So, and that harm means that they're going to have a side effect to the medication, they're going to misuse the medication, and require evaluation. So is that a reality? Absolutely. I mean, we can't ignore that. But I think it's blown so out of proportion to the number of people that it has the capability to help that we have to design the systems around how we deliver it to the highest number of people who need it, and for the right patient at the right time and the right treatment. I mean, to be able to deliver those things appropriately is how we need to design the system. Not continually adding barriers or allowing gaps to go unfilled. So let's dig into those a little bit. What are these gaps in treatment? So everything that needs to be, should be available for patients in treatment is you should have the ability to do detox, and that's both inpatient and outpatient, because that's step 1 is detoxification. Step 2, they need to be able to have evidence-based behavioral therapies, meaning cognitive behavioral therapy, facilitated 12-step, motivational enhancement therapies, solution-based therapies, contingency management therapies. There are a lot of evidence-based therapies that when applied to this group significantly improve outcome. We need to have availability of the medications that these patients need, and that's not just for opioids. I know that's what we're talking about now, but there are still 3 times as many people with alcohol use disorder as there are with that. How many of them have access to injectable naltrexone or oral naltrexone or acamprosate or baclofen or gabapentin, these medications that all have good data to be utilized for alcohol use disorder? Very few. I mean, very few primary care doctors have any training to be able to do this, but you have to have these medications available without significant barrier. But as we talked about on the governor's task force, we sat down and I said, it's really it's nice for people to feel like we're going to do the right thing, but we got to start in the right place, which is why do we have artificial barriers in place for patients to be able to have access to medication? Chronic neurobiological disorder with only 1 year of allotted treatment? That's weird. Doesn't make sense. It doesn't meet even the basic sniff test. Diabetes, type 2 diabetes is secondary to a genetic risk, bad nutrition, general lack of exercise. That, 85% of people with type 2 diabetes would not need insulin if they exercised, changed their nutrition, lost weight, and did those things. But we don't exactly say, you get 1 year of insulin, you better frickin' figure it out. And if you eat a Krispy Kreme, you're fired. We don't do that. You know what we do? We say that people have the right of free will. They have the right of choice. They have, this is America, we talk about this all the time. I can't force you into getting better or doing different, but what I can do is offer you the evidence-based treatments to be able to do so and continually push on the things that will improve your life. But we can't get access to these. And so there are places that when I talk about those 3 basic pillars, and if we talk about other levels of care like intensive outpatient therapy, 12-step modalities that actually have, that are okay with people on medication-assisted treatment, because this is a problem in that a lot of the historical 12-step modalities actually push hard on these patients to stop any medication that they're on, despite the data science and math that shows us that we have good outcomes from that. What about the recovery-oriented systems of care? Remember, we just built that whole thing in our state a while back? What does that mean? It's chronic disease. That means that once you treat it and you're good for a year, you're not done. This is a lifetime risk. And DSM-5 allows you to actually meet for remission prior to 1 year in early remission. And after 1 year, it's called late remission. And I think that's actually the best way to talk about it. I was really happy with the DSM-5. It's not perfect. Nothing is at this point. But at the same time, it allows me to tell a patient that your disease is in remission because your behaviors are gone. Those behaviors associated with the drug are gone, your function is improved, you're working, you're taking care of your family, you're thinking about things in the future and not just to right now. And so when we start to look at this, we can get a person in long-term remission past 1 year, but we need to do checkups, right? We do this for somebody who had BRCA1 malformation, which is a breast cancer genetic code malformation. They get a mastectomy, they go through treatment, and they even get put on a long-term medication called tamoxifen as a baseline medication. We don't think twice about the possibility of that coming back. We assume it's going to come back, and so we monitor heavily for a very long time, if not forever. Why we haven't been able to adapt that same modality for the treatment of addiction, I'm not really sure about, because it just makes sense based on the fact that we have rock-solid neuroscience that says that this is a chronic neurobiological disorder. We have a large number of patients that will benefit from medications, and all patients that will benefit from the behavioral therapies that can be approached if they're done in the evidence-based way. So when I started to look at this, and I'm the medical director for our region, our PIHP region, Lakeshore Regional Partners, and when I look at this and I've been trying to do an inventory of what's around and what we offer, I actually have 3 of my 7 counties that I would label as a treatment desert. They don't have one board-certified addiction doctor. They don't have one person who writes for buprenorphine or prescribes naltrexone. And they don't have access to a methadone clinic. So this is kind of weird, right? If you have any other disease, if you have a heart attack and you're in Iron Mountain, they will helicopter you to somewhere to get taken care of. They will put you in a helicopter and they will fly you to somewhere where they can get a heart cath. But up there, they're just like, man, that totally sucks to be you. That's it. And the saddest part is that's happening in 3 counties around the 2nd biggest urban area in the state. So, in fact, in our county, it's happening. In Kent County, 600,000 people sitting in Kent County, and we still have to turn a lot of people away, and still only 10 to 15% of people who are eligible are getting treatment. So one of the biggest barriers that we find, or huge gap, is screening. So what about universal screening? We do universal screening for a lot of stuff because we know that it has a propensity with generally within a 1 in 100. So we know that 20% of society has a substance use disorder based on the numbers. And so why is it that we're not actively screening in every primary care office and pediatric office? That doesn't make any sense. So I looked at the practices on this side of the state and on my side of the state and put the data together about screening and pregnancy, because in my clinic we see the vast majority of pregnant patients on a controlled substance. You know what I found? It's pretty scary, pretty sad actually, is that screening was not universal. It was done when they thought they needed to do it, right? So that by itself is a little bit weird, you know, that you're not trained in this and you're making a decision about when you needed to screen somebody. But then when I digged into the data of who they were screening, that became really problematic. And this is on both sides of the state. And actually now I just looked at Traverse City data and data from Philadelphia, where I have some friends that, you know, to look at the same thing. And it matched all over. If you don't have universal testing, what we have developed is a massively racist system of testing. In Grand Rapids, we have 14% of our population that's African American. 86% of our people who were randomly tested were African American. What? That makes no sense. I mean, it does, but we don't want to ever address that reality, right? So let's talk about what we have to do that. Why is screening not paid for? Why is doing a screening tool why is that code not opened up? Why is that? I mean, the code's there. It's not like somebody hasn't thought about this in the past. I mean, there's a code sitting there that says screening. You know, why aren't primary care doctors, you know, asking everybody who comes in and every OBGYN doing both an oral, like a conversational screen, as well as a toxicological screen? Because we're still freaked out about this disease. Which brings up the biggest barrier that we have, which is stigma. And so if we don't look at what stigma causes for these patients, then we're really in trouble, because we have people from all over the map socioeconomically that have this disease. Now the ones, and I talk about them as the haves and have-nots. From the neuroscience perspective, this disease beats up on the dopamine axis of the brain, the happy part of the brain. There are people who waited till later in their life to beat up on the happy part of their brain, and those are the haves. They have dopamine, which means they have motivation, all right? The have-nots are the people, they're generally what I see, which started at 12 to 14, early life trauma, really unstable home life, or if they even have a home life. And those are patients who beat up on that part of the brain so much that they do not have dopamine to spare. They barely have enough to even function. And those are the patients who we need to be able to apply medication-assisted treatment to at a higher level. So we've been arguing about this, and I came into addiction from the neuroscience perspective, not from the treatment perspective. And so when I came in, I was just, you know, kind of looking at it from a neuroscience, and I was like, wow, we have two different brain diseases. We have one brain disease of the haves, and that's why we have a group of patients, what I call kind of the doctors, pilots, and lawyers group. And that group actually doesn't need medication generally. They do pretty well without it. 90% of the time, they're clean at 5 years. We have different systems of care that work for them. What if we apply that same abstinence-based program to the have-nots, the people who started early with early life trauma? It's about 8% effective. So 92% not effective. So the people who say 12-step works, abstinence-based works, they're right. But it works for this group. It does not work for this group. And so what we have to be able to do is just understand that we have two different brain diseases that it probably fits on this very long spectrum, with two big humps on either side and a lot of people that kind of sit in the middle. And if we look at it that way, we have people over here that if we take a history and we understand what their early life trauma is, we know how long they've been using, we know what they've been using, we know what their behavior is, then we can determine very quickly whether or not this is a group that needs medication or an individual that needs medication. So does medication fix this problem? No, no freaking way. Are you kidding me? This is a societal issue. You know, these people destroy their home lives, not meaning to. This is just the aftermath of this. They destroy, you know, the whole unit around there. And this happens as a part of the disease, because a part of that disease is with lack of dopamine goes a lack of ability to plan, a lack of ability to risk assess. And so you make decisions, or actually decisions are made for you because there's no forethought. There's only action-reaction in this disease when it's not treated properly. This is why we can take someone who's a chief of surgery and wonder why they walk into a back closet right after the OR and use fentanyl. Because even for them, I mean, this is a disease. We can think that's not logical at all. Of course it's not. This is not a logical disease. It's not logical for a person with type 2 diabetes to eat, you know, a half dozen Krispy Kreme donuts. But every time I go to Krispy Kreme when I sneak in because I'm like, oh, my kids wanted to come, but it's actually me, you know. being like, can I get a couple of apple fritters on the side and a little baggie that so my wife doesn't see it? I'm like out in a car eating that. It's sugar all over my beard. But the kind of a sad low point in my life sometimes. But the reality is that that's not a decision. That's not a decision anymore because craving supersedes frontal lobe. It supersedes forethought. It supersedes logical risk assessment. Because it's not like this, chief of cardiothoracic surgery just wrote a pros cons list on his whiteboard. Pros, feel freaking awesome. Cons, kill someone, lose my job, lose my license, have my family completely leave me. Let me see. No, it's not that decision, so stop attributing that level of thought to use. It is not. It is thought done. It is the same sentence of thought. So the thinking of using and the using are in the same sentence. There is no period or comma that goes to the next. So in treating that, medication will help to decrease that craving so that a patient can at least start to reclaim a lot of the normal decision-making pathways. But that's where behavioral therapies become so important. But what happens when the door's closed and somebody's delivering therapy? Do we even know that? So I was the chair of a committee for American Society of Addiction Medicine to build performance measures. So I didn't know anything about performance measures. I just, my job was to take these wicked smart people in the room, the PhDs that do this kind of stuff all day, and see if we can come up with a logical approach to how to check performance for people treating addiction. And the first one I wanted to do was figure out exactly how we measure good behavioral health therapy. In the 9 performance measures that came out, there's not one that measures behavioral health. You know why that is? Because we don't know. You close the door, somebody says, I'm doing cognitive behavioral therapy. They're like, so, what's up? Oh, cool, that's good. You should just keep going, man. That's awesome. Rock on. I mean, that's honestly what happens behind some of the doors where you have other ones that you sit down and it's regimented and very specific and manual driven on, on some of these aspects and really just one thing after the other. So I've gone to group therapies. Gone to 12-step meetings to sit in and gone to different group therapy sessions. If you don't train a person to work in a group therapy, then what you get is, dude, last week, totally lit. And I felt really bad afterwards, but it was pretty awesome because I totally hooked up and it was pretty sweet. That's like group therapy. It's like a war story. It's like, and then I got busted by the cops and then it was so it's like, then they try to one up and that's not therapeutic. So we need to understand that the heterogeneous way in which we're approaching addiction treatment has to stop. If this is going to become, have the science of the treatment follow the science of the disease and have it be homogeneously approached on an individual level. So when I say homogeneously approached, I don't mean that, everybody gets this med or everybody gets this therapy. What I mean is when you sit down with the patient and you decide that cognitive behavioral therapy is what they need, that's what they get. That if you're going to decide that buprenorphine is the medication that they need, that you're going to write it based on the guidelines that have good data, because writing it for the highest dose for forever is asinine. There is no data to support that. The data shows that after a period of time, that dose should be decreased to 8 to 12. Are there going to be outliers? Yeah, sure, absolutely. But those are outliers. That shouldn't be the major piece. What about the patients who would do well with naltrexone? Is it everybody? No. But the people it works for, it's amazing. I use this med all the time. What about methadone? I've never talked about a medication that people had more emotional angst about a medication. And I always laugh because, there are more people hospitalized in the country annually for blood pressure medications than there are people, hospitalized for methadone. And there's probably, and we're looking into this, I'm working with the CDC on this right now to determine if there are actually more mortalities secondary to improper use of blood pressure medications when you talk about also the falls and postoperative from the broken hips and stuff that happened with that. But I've never heard either a crowd or a cardiologist be like, ban the calcium channel blockers. They don't do that, right? There's nothing connected to the medication. It's science and data. It's a risk benefit for everything. Now, the way we approach methadone clinics right now, it's antiquated. I mean, it's old. And having, one drug for one disease with one doctor is a massive waste of resources. So we shouldn't really have methadone clinics anymore. If you want to fill the gap, turn methadone clinics into modified medical homes and make that a part of their contract. But then pay them to do that appropriately, which means you can onboard primary care inside of there, because God forbid somebody with an opioid use disorder gets a flu shot, or Pneumovax, or hepatitis C, evaluation, or treatment. Or if they also have a marijuana use disorder or a benzodiazepine use disorder, that those get treated with the same level of fidelity as does the opioid use disorder. Or why is it that in these clinics they don't use buprenorphine or naltrexone on a regular basis? That doesn't make sense either. So we have to all be willing, those of us that talk about harm reduction as what we're doing, yes, that's a start. If that is your end and you are in treatment and you say, the best I hope to do is decrease their harm to themselves and to society, then I would like you out of my specialty. Because that is where we start. It is not where we finish. Are there patients that will get stuck at that level, that have just so broken their brain that we're just kind of, the best we can do is harm reduction? Absolutely. But if I hear another person tell me we're in harm reduction mode with a 23-year-old who's pregnant, I'm going to have to actually lose my cool a little bit, which maybe I do every now and then. But at the same time, let's think about this. I mean, that doesn't make sense. If we had a patient who's 23-year-old with a cardiomyopathy who was pregnant and, or just had another kid and has 2 other kids at home and they needed help, they would be on the heart transplant list. They would have a left ventricular assist device implanted. They would have the best minds at Henry Ford focused on what they could do, to get this done, right? This is just what would happen. But you take away cardiomyopathy and you make it an alcoholic cardiomyopathy, and immediately we've completely changed the path. Now it's more like, how can I get CPS involved? How can I get the kids away from them? It's more that. And that's a stigma problem, not a medical science problem. So we as a society and those of us in here represent a large, cross-section, if not the entire cross-section of society. I would say we probably need more patients. We always do, because their voice is a lot of times not heard in this. But at the same time, if we develop appropriate payment models, which, by the way, we've developed, those are known entities. It's not like unicorns and rainbows. I mean, this stuff exists on how to pay for this. We know that if you treat substance use disorders appropriately, especially in patients who are either pregnant or at risk early, you significantly decrease their total cost of care. I mean, that's now science. That's hard science now. That's prospective randomized controlled science. We know that if you have the long-term approach to treatment, at minimum of 5 years, then what we see is a significant solidification of improvement for these patients. So why is it that we have an arbitrary time limit on any of the medications? I mean, we worry about budget, at the state. I get this. I mean, there's a finite amount of money. There are a finite number of people willing to allow for appropriations for things. Fine, we've elected that cohort of people. And so when we elect that cohort of people, what we have to do is tell them, yeah, except for this. And we have to tell them that loudly. Because at this point, we don't have the system in place to even see who's getting what prescriptions on a consistent basis. We don't even allow for the access to these medications on a consistent basis. We haven't effectively incentivized the medical system to be able to deliver these in an appropriate way. I mean, we haven't really done a lot of the groundwork that's required in order to fill any of the gaps that we've recognized. So a lot of people want to put this problem onto primary care. How many people in here are primary care docs or work in a primary care setting? Right. You know why there's not more? Because they're working. They are busy. And my primary care colleagues, when they walk in, they see patient after patient after patient after patient, because that's what they do. And we're like, man, this system is so bad. You know why we have this system? We have the system we deserve, because this is the system that we have designed the payment model around. We have the system that is paid for. If we want to change the system, we do have to sit down and think about how we change the system by which we pay for the system we want. And we have to value the treatment of this disease as much as we value the treatment of an ankle surgery. As much as we value the treatment of my C-spine surgery. I valued it. I had surgery on a Wednesday, was back at work on a Monday. I could barely even sit at work, and now I'm doing triathlons. I mean, because I had that surgery. Without it, No, I would have, if I would have been not me and didn't have my friend at the Minimally Invasive Spine Center in Atlanta to tell me who to go to, I would have either had a surgery that would have doomed me to long-term bad outcomes because it would have just been slowly worsening over time, or I would have been on opioids, like a high dose, because my pain was neuropathic, which means my nerve was injured and being crushed, and that pain is resistant to opioids. So they would have cranked it up and cranked it up and cranked it up, and then been like, well, I don't know, here's a benzo, maybe that'll help. Help you what? Be in basically a mental coma, because it shuts down all of cognition. And at that point, you lose people with any emotional connection. And I talk to a lot of families and my patients when they do get better and they get clean, you know, off of these medications. I hate that term, but it's a term in these meetings with a lot of people that everybody understands. But when you get them stable in their disease and they're no longer using these medications, they look at me and they go, you know, I don't remember feeling anything. And that was a part of the reason that they had started, because they were feeling things that were unpleasant. And unfortunately, they started back when they were like 12 or 14, when they stopped learning how to feel. And so if you have someone who started, and this is the first question I ask a patient, I go, when was the first time that you started using a drug on a consistent basis? You know why I ask that question? Because that tells me the age at which they emotionally stopped growing, because they chemically coped from that point on. So if I have a 28-year-old who started at 14, emotionally, I have a 14-year-old. And we have to start from that scratch and understand that the way I interact with them, the ups and downs of their emotion is going to be very much like a regular 14-year-old, because they stopped having to make their own chemistry inside to be able to do it, because we augmented that with a lot of stuff on the outside. Screening, number one. Right? Access to evidence-based treatment. And this means that everybody in every PIHP region, including the payer arm of that and the provider arm of that, needs to answer to what and how they're doing what they're doing. We need to see benchmarks. We need to see outcome measures. We need to see performance measures. We need people looking over their shoulder to the point where we know what's going on. And I'm saying over my shoulder, come on in. Happy to show you what we do. Happy to change if the data changes. So as we look at this, these are the things that we're going to need to do. The state should do away with time limits on medication. So I wrote these guidelines, the medication-assisted treatment guidelines for opioid use disorder, at the Jim Haveman before he retired, and the group at the Recovery Oriented System of Care asked me to write these for the state. So I wrote these evidence-based guidelines because there were none out there, put behavioral therapies in there, and Jim Haveman's last thing he signed off was adopting these guidelines for the state. Very specifically in there, I put a paragraph and in bold said, no timeline should be placed on treatment, only outcomes. So they've adopted this, but yet from a policy side, that doesn't necessarily match. There are easy things. That's an easy thing to switch. You just say, oh, okay, I just need an update every year so that I can make sure we're going on the right path. Because what I don't want to do is change one drug for the other. I don't want to give them no behavioral therapy, no wraparound services, and none of the housing stability stuff and none of that, and then now just have them hooked on a different medication 7 years from now. Chronic neurobiological disorder does not mean that everybody chronically needs to be on a medication. It just means that we have to be aware that this is it. Most patients, after 2 years or so, we'd be able to slowly wean, consistently get down. That's not everybody. Some people will need that dopamine replacement forever, but most don't. So how do we build a system that's built for that? To slowly wean them off appropriately and do that in an effective way, but not have that be a must or a have to. That's the sweet spot. You know, this takes performance and dashboards and databases and things like this. So what I would say is, while you're here today, find your counterpart. If you're a provider, find the payer in your region. If you are a payer, in this room, you will find the people who are delivering care in your region who you've never met, because mainstream payers don't necessarily pay for this care outside of commercial. You know, the payer I work with, Priority Health, because I work for Spectrum Health and it's a part of that, has found that actually paying for a lot of the wraparound services for addiction significantly changes their bottom line by about 35%, by adding to this. And that 35% decrease in total cost of care is a reason that even though you're not obligated by the state contractual relationship to be able to pay for things related to addiction, you should, because it is good business, and it is good patient care, and it will significantly increase that. This story is about halfway done. Not my talk, that's almost done. But the story's about halfway done. We've identified evidence-based treatments. We've identified the gaps in care. We've identified the barriers to that care. That's really the first start, right? You're going to build a business, you want to sit down and you want to say, all right, what is the end product that we want? What we want is a society that has significant, like the vast majority, 9.5 out of 10 people, but you say blue sky. What's our blue sky view? I want 10 out of 10 people treated, having access to evidence-based treatment for addiction, which means you got to screen everybody, which means you got to have access to get people into treatment, and primary care can't own it, all right? Which means we have to build appropriate specialty services that are directly connected to primary care so that they can work as a unit, and then integrate behavioral therapy into the medication-assisted treatment, because just somebody, writing medication out of an office for their 100 patients for buprenorphine is not treating addiction. It is only one piece of that. So we are rewriting the regulatory framework within LAURA to mandate basically that if you have a large number of patients on any medication or with addiction, that you have a contractual relationship with a licensed behavioral therapy group in the state. And if you don't, I'm sorry, you can't do it. Because I want to improve access to treatment as much as anybody else, probably more than most, but not by increasing access to bad care. We have a chance that if we build this system right now, that it will be able to, from a population health standpoint, attack every other disease that we need to do, because integrated, connected care focused on opioid use disorder is great, but the next one's benzodiazepine use disorder. The next one after that's marijuana use disorder. And the next one after that, my kid's gonna have to deal with. So we have the capability to fix these problems. They are not unsolvable. This is not landing on Mars, which, by the way, we've already done with stuff. So we just need to look at paying for evidence-based treatments, sit down and agree on what those should be, and then we have enough PIHP regions that we could even start pilots within each of those to see which one works best. But it has to be coordinated, and it has to be focused on the patient, not on the silent. And I am fully aware of the money issue. I am not a naive, idealist. I am a payer in one of my jobs. I have to decide who I pay for. And that's tough, because I've turned off payment for a lot of stuff that doesn't have good evidence behind it. I don't detox my 55-year-old homeless alcoholics anymore who've been through detox 4 times. I just don't. You know why? It doesn't work. It just doesn't work. Those are patients that you put into stable housing and allow for outpatient treatment to work. And then that money gets rotated over to the things that we know works. Those are hard decisions. I'm having to say no to somebody. I don't like that. And so as we start to move forward with each of those, we have to know that we will have to say no to things that feel good but maybe don't give us the outcomes that we need. We will have to say yes to those that give us value, even if the stigma makes it feel weird. And as we start to build those systems, we have enough data at the national level to be able to deliver integrated models of care that will help us from an infrastructure standpoint to be able to treat any other population health-based disease that we come upon. So when Zika virus takes over the world, we could actually train a well-built addiction medicine system to handle something like that from a population health standpoint. I mean, there are endless and boundless ways for us to be able to utilize a well-built system of care. So I would challenge everybody in this room to think about how we do it together, and how we do it with evidence. And I will leave you with that. Thank you.